Hello everyone, welcome to our channel Nanjilnas. Today we are going to see a disease condition in gastrointestinal system, that is gastritis. Let's go into the video. First, let us see the definition of gastritis. Gastritis is one of the most common problems affecting the stomach. It is defined as the inflammation, irritation or erosion of gastric mucosa. So gastritis is defined as the inflammation, irritation or erosion of the gastric mucosa. Next, let us see the incidence of gastritis. In India, about 25 to 35% of the total population is affected with gastritis. Now, let us see the types of gastritis. Gastritis can be classified into three main types. The first one is according to the duration of mucosal involvement. The second one is according to the degree of mucosal involvement, and the third one is according to the area involved. The first classification is according to the duration of mucosal involvement. Gastritis can be classified into acute gastritis and chronic gastritis according to the duration of mucosal involvement. The first one is acute gastritis. Acute gastritis involves sudden and severe inflammation. It can last for a few hours to a few days. Second one is chronic gastritis. Chronic gastritis involves long-term inflammation. It can last for a few years if it is left untreated. The second classification is according to the degree of mucosal involvement. So gastritis can be classified into erosive or reactive gastritis and non-erosive gastritis according to the degree of mucosal involvement. Erosive gastritis involves both inflammation and erosion of the gastric mucosa. But in non-erosive gastritis, it involves only inflammation without erosion of the gastric mucosa. The third classification is according to the area involved. So gastritis can be classified into diffuse gastritis and localized gastritis according to the area involved. Diffuse gastritis, if the inflammation and erosion of the gastric mucosa spread over a wide area, it is called diffuse gastritis. Localized gastritis, if the inflammation and erosion of the gastric mucosa is restricted within a small area and does not spread, it is called localized gastritis. Next, we will see the etiology of gastritis. The first etiology is drug-related gastritis. So gastritis can be caused by long-term use of drugs like non-steroidal anti-inflammatory drugs including aspirin and corticosteroids. The examples of non-steroidal anti-inflammatory drugs are diclofenac, ibuprofen and indomethacin. Examples of corticosteroids are prednisone, dexamethasone and hydrocortisone. When these drugs are taken, they inhibit the synthesis of prostaglandins that are protective to the gastric mucosa. When the prostaglandins are inhibited, it will cause breakdown of the gastric mucosa. The second etiological factor is dietary factor. So dietary factor includes excessive intake of alcohol. Alcohol stimulates increased secretion of gastric acid. Then increased intake of hot, spicy and irritating foods will lead to gastritis. And the third one is excessive intake of carbonated drinks. And the fourth one is excessive intake of coffee. These all can lead to increased gastric acid secretion. The third etiological factor is Helicobacter pylori infection. Helicobacter pylori is a gram-negative bacteria. This bacteria can infect people through fecal-oral route or oral-oral route. Helicobacter pylori can get attached to the epithelial cells of the gastric mucosa and it gets multiplied there. This bacteria can produce an enzyme called urease to protect themselves from the gastric acids. This urease can break down plasma urea into ammonium chloride and carbon dioxide. This ammonium chloride can break down the gastric mucosa. The next etiological factor is autoimmune gastritis. Autoimmune gastritis is otherwise called as autoimmune atrophic gastritis. In this condition, the parietal cells which are present in the fundus of the stomach will be destroyed by the body's own immune system. So, there will be presence of ulcer in the fundus of the stomach. So when the parietal cells are destroyed, there will be decreased production of intrinsic factor, which will help in the absorption of vitamin B12 from the small intestine. So when there is decreased intrinsic factor, the absorption of vitamin B12 from the small intestine will be decreased, and it will lead to a condition called pernicious anemia. Next, we will see about the other risk factors associated with gastritis. The first risk factor is incompetent pyloric sphincter. If there is inflammation near the pylorus, the gastric contents cannot pass from the stomach into the duodenum. So there will be increased production of gastric acid and it may lead to gastritis. Second one is reflux of bile salts. So when the pyloric sphincter cannot close properly, the bile salts from the duodenum will be reflexed back into the stomach, and this may lead to gastritis. Next one is Zollinger-Ellison syndrome. This is a rare condition. It is otherwise called as gastrinomas. Gastrinomas or tumors present in the upper portion of the duodenum. The gastrinomas will secrete a hormone called gastrin, which can damage the gastric mucosa. And next one is infections with the mycobacterium species or cytomegalovirus or syphilis can all lead to gastritis. Next, we will see about the pathophysiology of gastritis. Due to the etiological factors like helicobacter pylori infection, use of non-steroidal anti-inflammatory drugs and corticosteroids, then autoimmune gastritis, dietary factors, all these can lead to breakdown of normal mucosal barrier during the initial stage. So when there is breakdown of normal mucosal barrier, it will lead to the diffuse back of hydrochloric acid and pepsin into the broken down mucosal layer. So this will lead to cellular destruction and inflammation. That is, the mucosal cells will be destroyed and there will be inflammation. When there will be cellular destruction, the hydrochloric acid and pepsin which is present in the cells will be secreted more. Due to increased secretion of hydrochloric acid and pepsin, it will lead to increased mucosal erosion and bleeding. Next, we will see about the clinical manifestations of gastritis. The most common clinical manifestation of gastritis is pain in the upper abdomen. The pain is usually explained as burning pain, which is usually localized in the left upper abdomen, and this pain can radiate to the back. The next one is belching or burping. The excess air in the stomach is released through the mouth. That is called belching or burping. Next one is feeling of fullness of the stomach. The patient may feel fullness of stomach after a meal. Next one is bloating. Bloating is the sensation of presence of excessive gas in the stomach. This belching and bloating and the feeling of fullness of the stomach is due to the presence of helicobacter pylori infection. So the urease which is present in the helicobacter pylori infection will be converting plasma urea into ammonium chloride and carbon dioxide. So there will be presence of excessive carbon dioxide in the stomach. This is the reason for belching and bloating of the stomach. Next, the patient will be having nausea and vomiting. The vomitus may be clear or blood-stained or fully bloody vomitus. Then anorexia. It is the loss of appetite. Then the patient may have black stools. So black stool may be due to the hemorrhage in the gastric mucosa, and also red colored vomitus is also due to hemorrhage in the gastric mucosa. Next one is halitosis. It is the foul smelling breath. This is due to the presence of Helicobacter pylori infection. And next one is symptoms of anemia will be there for patients with chronic gastritis, chronic atrophic gastritis. This is due to the deficiency of intrinsic factor which may lead to pernicious anemia. Next we will see about the diagnostic evaluation of gastritis. The first diagnostic evaluation is endoscopy. Endoscopy is the most accurate procedure to diagnose gastritis. During this endoscopic procedure, we can view the gastric mucosa directly. And during the endoscopic procedure, a tissue specimen can be obtained for biopsy to find out the presence of H. pylori infection. The second one is biopsy and rapid urease testing. The tissue taken during endoscopic examination will be sent for biopsy. The tissue is placed on a medium containing urea. If there is presence of Helicobacter pylori infection, the urease present on H. pylori will be reacting with the urea in the medium and it will be releasing ammonium chloride and carbon dioxide. So the pH of the medium will be changed. This shows the presence of H. pylori infection. Then the third one is serum antibody test. In this test, there will be presence of immunoglobulin G, which indicates presence of H. pylori infection. The fourth one is urea breath test. In this test, the amount of carbon dioxide exhaled before and after taking a fluid containing urea will be compared. So, when the amount of carbon dioxide exhaled after taking fluid containing urea is more than the carbon dioxide exhaled before taking urea fluid, it shows the presence of H. pylori infection. Next is stool antigen test. This is done to identify if there is any antigen present for H. pylori infection. Then sixth one is barium contrast study. In this, an X-ray abdomen is taken after a barium meal. This shows any inflammation of the gastric mucosa in the X-ray film. Next, CBC. CBC is done to identify if there is any presence of anemia due to autoimmune atrophic gastritis or bleeding in the gastric mucosa. Next is the management of gastritis. First, we will see about the medical management of gastritis. The first group of drugs which can be given to treat gastritis are H2 receptor blockers or histamine receptor blockers. These drugs are given to reduce gastric acid secretion and to promote ulcer healing. Examples of H2 receptor blockers are ranitidine, cimetidine. Second group of drugs which are given to treat gastritis are PPIs or proton pump inhibitors. These drugs also can reduce gastric acid secretion and promote ulcer healing. Examples of PPIs are omeprazole, lansoprazole. Next, antiemetics are given to reduce nausea and vomiting. And next, cobalamin is used to treat pernicious anemia due to autoimmune atrophic gastritis. Cobalamin can be given as injections or orally. Next is the antibiotic therapy. Antibiotics are used to eradicate Helicobacter pylori infections. There are two types of antibiotic therapies for treating Helicobacter pylori infection. The first one is triple therapy and the second one is quadruple therapy. Triple therapy, in this therapy, 3 drugs are combined to treat Helicobacter pylori infection. The first one is proton pump inhibitor, example omeprazole. Then amoxicillin and clarithromycin. These two are antibiotics which can kill Helicobacter pylori infection. These 3 drugs can be given for 7 to 14 days which can eradicate 75 to 85% of Helicobacter pylori infection. Next one is quadruple therapy. In this therapy, 4 drugs are combined. First one is proton pump inhibitor, example omeprazole, and the next 3 are antibiotics, bismuth salt, tetracycline and metronidazole. These 4 drugs can be given for 10 to 14 days which can eradicate 85% of Helicobacter pylori infection. Next is the antacids. Antacids help to neutralize the hydrochloric acid and increases the pH of gastric acid. Examples of antacids are aluminum carbonate and gelusil. Next is the cytoprotective drugs. These drugs form a protective layer in the GI mucosa. Example of cytoprotective drug is sucralfate. Next one is prostaglandin. Prostaglandin also serves as a protective layer in the gastric mucosa and it has anti-secretory action. That is, it decreases the gastric acid production. Example of prostaglandin is misoprostol. Next we'll see about the nutritional management of gastritis. So first we have to reduce or eliminate the intake of alcohol. Second one is we have to reduce the intake of spicy, hot and irritating foods. Third, we have to reduce the intake of beverages and food containing caffeine. Fourth one, we have to reduce the intake of carbonated drinks or beverages. Next, we will see about the nursing management for patients with gastritis. First, if the patient is in acute gastritis, they will be having severe nausea and vomiting and dehydration. To treat dehydration, we have to give IV fluids as ordered by the physician. Next, we have to keep the patient in nil per oral state. NPO is maintained to identify if there is hemorrhage in the gastric mucosa and also to remove the gastric contents from the stomach. And then we have to give clear liquids and bland diet for patients recovering from acute gastritis. And then we have to administer drugs like pain medications and anti-ulcer drugs to treat gastritis as ordered by the physician. Next, we will see about the possible nursing diagnosis for patients with gastritis. The first one is acute pain related to inflammation of gastric mucosa. The second one is imbalanced nutrition less than body requirements related to insufficient absorption of nutrition. This nursing diagnosis can be written for patients with pernicious anemia due to autoimmune atrophic gastritis. Next one is risk for fluid volume deficit related to vomiting. The next one is knowledge deficit related to unfamiliarity with the disease process. Dear viewers, thank you for watching the video. I hope that this video will be helpful for you. If you like this video, kindly like, comment and share the video with your friends. If you are new to our channel, kindly subscribe and press the bell button to get notifications. Thank you. Have a great day.